So we'd like to welcome everyone to the 21st Century Trends in Mental Health Care Conference evening session, which is entitled Mental Health and Healthcare Reform. My name is Eric Giordano. I'm the director of the Wisconsin Institute for Public Policy and Service. And we are co-hosting this event with the School of Medicine and Public Health. And we're very grateful for that partnership. We also have some wonderful partners from here in the community and around the state, which are listed in your program, including in alphabetical order, Aspirus, Community Health Connections, Elmer Green Associates, Family Counseling Services, Marathon County, Marshfield Clinic, Ministry Healthcare, the National Council for Community Behavioral Healthcare, and North Central Healthcare, our own UW-Marathon County, and the Wisconsin Area Health Education Centers. I'd also like to acknowledge and thank the Conference Planning Committee, who are listed on the back of your program. I'm not going to formally introduce them here. I'll introduce them tomorrow during the morning session, but we're grateful for the work that they have put into planning this event. We'd also like to thank the Dean of UW-Marathon County, Keith Montgomery, and UW-Marathon County staff, including Chris McCaslin, Chris Berg, our crack maintenance crew, our WIPPS interns led by Rowan Lee, Jean Greenwood and Connie Nicolai, and our special guest Danielle from the School of Medicine and Public Health. We're grateful for your help tonight. At this time, we'd like to please ask you to silence your cell phones and pagers if you have them. I'd also like to remind you that at the conclusion of both our speakers tonight, we'll have a question and answer period, and we will have some interns who will have microphones. And if you'd like to ask a question, just raise your hand and they'll come by and present that. We'd like to ask that you be respectful of our guests tonight as well as our fellow audience members, and therefore limit your comments to questions only. We'd also like to acknowledge the presence of city, county, state, municipal leaders who might be with us tonight. And I'd like to also especially welcome Bryce Luchterhand from Senator Cole's office. Bryce, are you here? Bryce has mentioned to me that he'll be available for constituent feedback if you're interested after the event tonight. Thank you for being here, Bryce. Thank you, guests. Thank you, audience members. For those of you who are from our community and are wondering why there's a registration table for a community event, it's because this really is part of a two-day conference, and so some of you may be registered for that conference. Others from the community, you do not need to register for the conference, but we certainly welcome you and are grateful that you're here tonight. And why this conference? This conference really was the germ of an idea from one of our own community members, Annie Benedetto, who came to the university and was concerned about the status of mental health care in our community, in particular, asking a key question, which is, why is it that when we talk about basic needs in our community, we often neglect one of the most fundamental needs of all, and that is mental health? What is it about our community and what is it about mental health that make this such a difficult topic of conversation, and how can we as a community better address this issue? So the original idea was that we might hold a community conversation about this event. But as we started talking and bringing in other partners, those of whom I've already mentioned in the planning committee, we came to the conclusion that in order to really talk about mental health at the local level, we also needed to understand the important changes that are taking place at the state and national level. So it became obvious that in that context, we needed some expertise. And for that reason, we've invited, and we're very fortunate to have several guests who will be joining us for this conference who can provide some policy expertise to help us understand how mental health is changing. And in particular tonight, with reference to the Affordable Health Care Act, which is a very important piece of legislation, as we all know, if a little controversial, that has direct ramifications on health care and mental health care in particular. So if you are joining us from the community, I would like to just mention that if you would like to actually join the portion of the conference that is going to be dedicated to that community conversation, which was the original concept, you are welcome to come tomorrow afternoon at 2 p.m. There is no charge to come to that specific community conversation, and so if you're interested, we'd ask you to stop by the registration table and just make sure that you sign up, not because of the cost, but because we want to make sure that we have enough space for you, because there is limited seating for that community conversation, but you are certainly invited. For those of you who are here for the conference, I just want to call your attention to a couple of things in your folder, one of which is your attendance verification, and also this is particularly important for those of you who wish to receive AMA PRA Category 1, I have to make sure I read that because I haven't got that memorized, credits or continuing education credits. You'll need to print your name and fill out, for example, how many hours that you attended tonight, which according to the form is a maximum of 1.5 hours. When you're finished filling out that credit sheet at the end of the conference, you'll be asked to turn that in a box at the registration table to make sure that you can indeed receive your credits. In addition to those registrants for the conference, in your packet you also have an evaluation form, and we'd like you to please fill that out so that we can understand how we did with the conference, and your feedback will be very important to the conference sponsors. So we'd like to ask you also to keep that in mind and also turn that in at the end of the conference. Thank you again for being here. And with that, I'd now like to introduce our first speaker. Actually, before I do that, let me also just call your attention to one small housekeeping issue. Unfortunately, former Congressman David Obey will not be here tonight. He was ill and could not make it and sends his regrets. But we do appreciate his support and the support that he has given to mental health and healthcare generally. So we will miss him. Professor Mark Brown will introduce our special guest tonight in lieu of Congressman Obey. At this time, I'd like to introduce Mark Brown, who earned his PhD in philosophy from the University of Kansas. And from 1986 to 2011, Mark was professor of philosophy at the University of Wisconsin-Marathon County, where he challenged students to think clearly about the implications of modern science for including the ideas of Plato, Aristotle, Thomas Aquinas, and other great philosophers of the past. Professor Brown speaks to other scholars and others in public life through publications on bioethics, and he's very accomplished and well published in that area, in philosophical psychology and in the philosophy of religion, and at conferences like this. This year, Mark was a senior fellow at the Wisconsin Institute for Public Policy and Service, and he served as project manager for this conference, and we're very grateful for all that he did. And I just want to say one thing. Here we have tonight the coming together of an expert in liberal arts in the field of philosophy and an expert in policy. And this really is what this center and this type of conference is all about, is bringing together expertise to address important public issues such as this. So we're grateful that you're here, Professor Brown, and I'll turn the time over to you.
Thank you, Eric. When I was 12 years old, I was asked to introduce the principal at my elementary school. It was my first public speaking experience, and my mom told me, be brief and be seated. They want to hear about him, not you talk about him. So I walked up to the microphone and said, this is Principal Blackburn, and the less said about him, the better. I'm not going to sit down quite yet. I want to talk about mental health, its historical, philosophical context, something about contemporary development, certainly. Many of us have opinions about national health care reform, but one aspect that has not gotten much attention is the impact of the law for behavioral health care. Now, that's surprising because in the 2010 Patient Protection and Affordable Care Act that we've all heard so much about, together with the implementation of the 2008 Federal Mental Health Parity Act, constitute the most significant public policy changes in the field since the Kennedy administration. Chuck and Goglia, our distinguished guest from the National Council of Community Behavioral Health Care, we'll talk about all this in more detail. But before he does, I would like to draw your attention to a trend supported in the Affordable Care Act, but a trend which is already well underway: integrated health care. Health care traditionally is delivered through a primary care provider who makes referrals to specialists who manage particular disease categories and conditions: diabetes, heart disease, depression, autoimmune conditions, and so on. I am quite sure that I am alive today because physicians who specialized in what ailed me knew what to do, and I suspect that many of us have similar tales to tell. But the traditional approach also can result in a dangerous fragmentation of care with no one responsible for the overall health of the whole person. Patients with poorly controlled diabetes, for example, often also suffer from clinical depression. Mental health interventions can help patients accept their condition, elevate depressed mood, cope with a compromised body image, and gain perspective on feelings of hopelessness. These patients are more likely to adhere to the sometimes onerous treatment regimens for diabetes. If treatment for depression includes psychopharmaceuticals, possible weight gain and changes in appetite and sleep pattern need to be monitored and accommodated within the diabetes protocol. So it's important to treat both of them at the same time. Integrated care of co-occurring diabetes and depression has been shown to have markedly superior outcomes compared with specialty care of diabetes alone. Nor is the occurrence of diabetes and depression an isolated case. Note the chart. Note that a third of the people with medical conditions also have mental disorders, and that over 2/3 of people with mental disorders also have medical conditions. These people are among the heaviest users of healthcare services with some of the worst outcomes. Partly as a result, mental illness is the leading cause of disability over a lifetime. As many as a quarter of all Americans will have a mental illness at some point, and we all know that physical illness can strike any time. So if you think about this in terms of family and close friends, it affects virtually all of us. Here's one way the federal government has taken the lead in providing integrated health care and attempting to deal with this problem. In 2007, the Veterans Health Administration implemented primary care mental health care integration in all Veterans Administration centers and VA primary hospitals. So here we have a model which is well established. We have some data. The VA is the largest health provider in the country, serving the needs of nearly 6 million active patients, many of whom suffer from more than one chronic illness. Today, over 95% of veterans are screened for depression, alcohol misuse, and post-traumatic stress disorder as part of routine medical care. And then, depending on the diagnosis, veterans may be referred to a mental health specialist, crisis intervention, or a brief counseling session and follow-up treatment. Like any medical provider, the VA treats only with the informed consent of patients, assuming that they're neither a danger to themselves or others. And treatment may consist in nothing more than watchful waiting. You might be sitting there asking, why am I listening to a philosophy professor talk about how to run a clinic or what the best way to deliver medicine is? Well, like you, I'm following the political debate on healthcare reform, but I don't have any special expertise in medicine. I'm a bioethicist. Might have something useful to contribute about the moral problems in the practice of medicine, including those that might come in the aftermath of healthcare reform. But on this topic, on the topic of integrated mental care, health, physical care, I think philosophy can be helpful to clearly state and critically examine the assumptions that underlie the current trend toward the medicalization of mental health. Integrated care makes an assumption. The assumption is that mental disorders can be effectively treated in a medical context, in conjunction with the medical management of physical disorders. And the evidence in support of this proposition is fairly robust, although not entirely conclusive. The entire approach assumes a particular solution to a philosophical conundrum that has haunted psychiatry from the beginning. And this is where my expertise kind of comes in, the mind-body problem. May have studied this in school. So the question is, how can the human mind, the sphere of morality, spirituality, reason, freedom, the subjectivity of consciousness be so intimately connected to the human body, which medical science reveals to be a mechanism, astonishingly complex and resilient, but a mechanism nonetheless. People think and act on the basis of what they judge to be appropriate, reasonable, or justifiable. Their bodies, in contrast, sustain life through a finely tuned hierarchy of physical cause and effect. Bodily injury and illness are caused by physical forces. Physicians and surgeons respond biochemically or biomechanically. The body, unlike the mind, does not respond to appeals to sweet reason, moral goodness, social convention, or eternal salvation. As human beings, we all live parallel lives, a life of the mind, governed by reason, emotion, will, and judgment, and a life of the body, governed by the same laws as the rest of the physical world. Some people conclude that the mind must be non-physical, a soul, perhaps. Other people think that the mind must be a poorly understood part of the body, the brain probably, which can break down and can be repaired by those who know how it works. Either way, the mind-body problem remains. How is it that logic and feelings could change the way a machine works? How could brute cause and effect make a rational or a moral difference? Nowhere is the mind-body problem more pressing than in understanding and treating mental illness. What makes an illness mental, philosopher talking here, what makes an illness mental is a breakdown in the ability of a person to make reasonable and appropriate connections between their beliefs, desires, emotions, and actions. Unlike an epileptic seizure, meaningful connections are disrupted, but not displaced entirely. There is meaning in madness, but unlike mere foolishness, someone with a mental disorder cannot simply correct the error and then get back to leading a sensible life. There's more to it than that. For example, someone who is clinically depressed may know that there is no reason to feel so sad, that plenty of worthwhile activities beckon, and that they are not so worthless that the world would be better off without them. Still, cheer up. It's cold comfort. A person in the grips of a panic attack, or a post-traumatic flashback, or a phobic reaction of another kind may understand that his or her fear is completely out of proportion to the actual danger, and that the reaction is unreasonable, off-putting to others, and making them even more fearful and angry. Calm down. Doesn't help. Someone who obsessively ruminates over the same idea or who feels the need to do the same thing endlessly may know full well how pointless and unreasonable it is. Still, the thoughts and urges come unbidden. And at some point, most alcoholics and others afflicted with substance abuse understand that their desire for the drug is just disrupting every other meaningful connection in their lives, but nonetheless find it nearly impossible to stop. Willpower is insufficient. And even the delusions and hallucinations of psychosis, of schizophrenia, can be seen as essentially breakdowns in the coherence of thought. So with mental illness, the mind-body problem comes together, the mental and the physical. Somehow it seems mindless cause and effect has erupted into the rational and purposeful mind, disrupting the search for meaning in ways that the mind itself seems incapable of correcting. Mental health may be restored, it seems, only when those non-rational causes have been identified and controlled. This is a medical model of mental illness. This is my subject tonight. This is what is presupposed in integrated health care. It's what's presupposed in biological psychiatry. The medical model has a history. It's been around for a while. And I'm not going to bore you with a lot of history, just a little bit of context, if you don't mind. All the way back to the ancient Greeks and the philosophers. Hippocrates, author of the Hippocratic Code of Ethics in Medicine, thought that mental illness could be understood within the same causal framework as physical illness. So he avoided the mind-body problem. He just said mental illness is a type of physical illness. The body, according to Hippocrates, is in a state of disequilibrium. And that disequilibrium has both mental and physical effects. And treatment for physical illness and mental illness for Hippocrates was the same thing. It consisted in the restoration of the bodily fluids. Now, this was received wisdom for 2,000 years. And it's not a bad theory, given what was known at the time, but it got it completely wrong. And for those 2,000 years, it was used to justify incredibly harsh and harmful treatment for the mentally ill. They were chained, terrified, plunged into freezing water, starved, lacerated. Beware of helpful people with bad theories. a stunning success. Launched the medical model at the end of the 19th, beginning of the 20th century. At the turn of the 20th century, half of all hospital beds in Europe were occupied by patients believed to be mentally ill. Think about that. Half of all the people in Europe. And it turned out that half of them suffered from end-stage syphilis, the symptoms of which include hallucinations, incoherence, mood swings, and other thought patterns that are associated with serious mental illness. Identification of the cause, the spirochete, and effective treatment, penicillin, and public health, resulted in symptom remission and eradication of the disease in much of the Western world. A new world of psychiatric medicine had dawned, or so it seemed. The search was now on for psychiatric medical miracles. And the first step was to build mental hospitals. The first step was to build asylums where the mentally ill could be diagnosed, cured, and then restored to society. By the middle of the 20th century in the United States, over 500,000 people were in mental hospitals, many of them in incredibly appalling conditions, equally disturbing. No new physical causes or medical cures for mental illness were discovered. In an asylum setting, it seemed, mental illness was chronic, incurable, and progressive. In the 1950s, antibiotics, vaccination, and clean water brought infectious disease under control, out of the hospital and into the doctor's office. And for a time, it seemed like something similar was going to happen in psychiatry. New antipsychotic medications promised to produce a revolution similar to the antibiotic revolution and vaccinations in mid-20th century. But by the end of the decade, it became clear that extended use of what are now called typical antipsychotics were accompanied by high rates of serious side effects, not least upon the central nervous system. Indeed, much of the stereotypical behavior that contribute to the stigma of mental illness in the public mind, the awkward gait, jerking arm movements, head movements, darting tongue, vacant stare, are due in part to long-term use of first-generation antipsychotics. Other first-generation psychopharmaceuticals were introduced around the same time, notably the anti-anxiety drug Valium. But that also came to be viewed, as the 70s wore on, as sometimes doing more harm than good. Backlash against the medical model drove biological psychiatry into something of a state of crisis at the end of the 20th century. Since no one could identify the neurological causes of mental illness, some psychiatrists said the whole idea was a myth. What's called mental illness, they claimed, actually is just socially unacceptable behavior. Exhibit A was the classification of homosexuality as a mental disorder. Exhibit B was hysteria and personality disorders that appeared to affect only women who behaved in an unconventional manner. Exhibit C was the political abuse of psychiatry in the Soviet Union, and I guess Exhibit 4 was One Flew Over the Cuckoo's Nest. This entered into popular culture, the popular mind, a reaction. So in part for this reason, in part just to reduce the size of the federal government, in the 1980s, those mental hospitals, many of them discharged some of their most troubled patients. quickly overwhelming the resources of community mental health centers. Deinstitutionalization led to widespread homelessness, rising stigmatization, and reinstitutionalization of the mentally ill in the criminal justice system, almost always for nonviolent crimes, such as vagrancy or homelessness. It's something of a myth that people who are mentally ill are more likely to commit violent crimes. The evidence just does not bear that out. Nonetheless, the largest mental institution in the world, it's sometimes said, is the Los Angeles County Jail, with the Cook County Jail not that far behind. Now some cities and towns have upscaled their community mental health services in the form of group homes and expanded outpatient psychiatric and rehabilitative services, and other communities have let the police, our psychiatrist in blue, handle the problem. For psychiatry itself, the situation in the 1990s was so dire that the addition of the Diagnostic and Statistical Manual, sometimes called the Bible of the field, the edition that was then in use, the third edition, explicitly disavowed any causal explanations for the mental disorders it described. It would be enough if everyone in the field could just agree on what the diagnoses were and when and how much to charge the insurance companies. The medical model had lost credibility, even among the physicians who specialized in the field. Now, from a philosophical perspective, this is not a surprising result. The 20th century medical model of mental illness always was a high-risk promissory note. As a theory of how the brain generates consciousness and how meaningful connections can be disrupted, chemical imbalance in the brain is not much more informative than imbalance of bodily fluids in the body. In the last 15 years, the pendulum has swung back in favor of the medical model. It is resurgent, and it's important to understand what happened and why. Because integration of mental and physical health care is, once again, it seems, theoretically possible and clinically beneficial. Part of the reason why we're here talking about this is that it looks like there may be a way to treat both mental and physical illnesses in the same context. 3 intersecting trends occurred in the 90s and the early part of the 20th century that led to the resurgence of the medical model. First, mental illness is no myth. Data collection and analysis conducted by the National Institutes of Mental Health, Substance and Mental Health Agency, other government and private sector organizations have demonstrated beyond any reasonable doubt the reality of mental illness and its cost in public health, lost productivity, and human misery. Perhaps most striking, the average life expectancy of Americans diagnosed with serious mental illness is 25 years lower than other Americans, principally due to increased risk of cardiovascular disease, diabetes, and tobacco-related pulmonary disease. Now notice that integrated care programs are designed to treat precisely these co-occurring conditions. Now, mental illness itself can be a life-threatening condition. Certainly radically diminish the quality of life, but it can be life-threatening as well. Overall, 5% of the seriously mentally ill commit suicide compared to 1.5% of the population in general. 10% of schizophrenics find their life so unbearable that they end it. Half of the clinically depressed attempt suicide. 15% succeed. But statistics alone cannot convey suffering so profound. Here is William Styron, the author of Sophie's Choice, from his memoir of depression, Darkness Visible Mysteriously, and in ways that are totally remote from normal experience. The gray drizzle of horror induced by depression takes on the quality of physical pain. What makes the condition intolerable is the foreknowledge that no remedy will come, not in a day, an hour, a month, or a minute. It is hopelessness, even more than pain, that crushes the soul. And then there's this. I am now the most miserable man living. If what I feel today were equally distributed to the whole human family, there would be not one cheerful face on earth. Whether I shall be better, I can't tell. I awfully forebode I shall not. To remain as I am is impossible. I must die or be better. Abraham Lincoln. Second factor in the resurgence of mental illness, or the medical model of mental illness. There's been rapid advances on a scientific and technological level in genetics and neuroimaging. And these confirm the epidemiological findings. Now take a look at this and notice that there is a strong genetic component to these two leading types of serious mental illness. But notice 50% is not 100%. DNA is not destiny. Identical twins have the same DNA, but they don't develop schizophrenia, unlike some other genetic conditions. Now, functional magnetic resonance imaging and related brain scans, there's a lot of new technologies, but probably fMRIs are some of the most powerful. They open an absolutely fascinating window on the human brain. It's kind of like Galileo turning his telescope onto the skies and a whole new world emerges, or turning a microscope onto the human body and seeing cells and microbes. So these panels, they're labeled normal control, NC, schizophrenia, and bipolar disorder. We put those up because they sort of correspond to the genetic results. What they do is they reveal a characteristic pattern of metabolic activity as measured by blood flow. Now, this is a crude instrument. Measuring blood flow is not the same thing as measuring thoughts or feelings or emotions or desires, but it does provide a measure. These are baby steps in trying to understand the human brain. It's mind-bogglingly complex. There are 10 billion neurons in the human brain, and each of those has 1,000 synaptic connections to other neurons, and they fire in patterns that shift every single second, so there's just one little snapshot for one person. Still, the first decade of neuroimaging technology and of human genetics research powered by the Human Genome Project confirms a central tenet of the medical model of mental illness. Mental disorders have a physiological cause. Second, over the past 15 years, the Federal Drug Administration approved an array of new psychopharmaceuticals thought to be more effective, less toxic, and suitable for long-term maintenance, rather like insulin control for diabetes. Second generation or atypical antipsychotics such as arlanzadine, trade name Zyprexa, became the first line of defense against the onset of schizophrenia. But most significant from a public health standpoint was the mass marketing of a class of antidepressant and anti-anxiety medications. By 2011, among the most widely prescribed medications in America were fluoxetine, trade name Prozac, and related serotonin modulation medications. Other new psychopharmaceuticals, notably Prazolam, trade name Xanax, were not far behind. Now, Primary care providers write 60% of these prescriptions, and often without coordination with mental health staff or much in the way of follow-up care. And I'm not criticizing primary health providers here. I'm just saying that is how the field has developed. Integration of mental health into primary care, though, is worth keep bearing in mind, it's already happened. It's already happened in the private sector. Mental health care is already being provided in the form of psychopharmaceuticals, first line of defense, through primary care physicians. The Affordable Care Act provides some regulatory framework and some evidence-based research and some incentives to upscale programs at work, integrated care programs, perhaps. So back to my story. By the end of the 20th century, traditional psychotherapy, psychoanalytic therapy, as practiced by Freud and his successors, was in steep decline. The field was beset by internal divisions, challenges to scientific legitimacy, and from most significant from our perspective, meager evidence of clinical effectiveness. It seemed like one could be in therapy for years, decades even, without measurable remission of symptoms. But something has happened recently. Alternative talk therapy techniques have been shown to have clinically significant benefits after a dozen or so relatively brief sessions. Now, there are a number of new talk therapies that you may or may not be familiar with. Perhaps the one which is best known is cognitive behavioral therapy, which seems to enable many patients, in some studies, the majority, to cope effectively with depression and post-traumatic stress disorder and anxiety disorders, and in some cases, even schizophrenia. Now the method of cognitive behavioral therapy is pretty straightforward and is patient-centered. The therapist and the client together identify the event that's triggering an unjustified and disproportionate response, some type of behavior, which involves a breakdown and a meaningful connection. And then behavioral conditioning techniques are used in order to help the person to inhibit their ingrained and dysfunctional response. And then the therapist and the client together identify the unconscious mistakes in reasoning that might be made, not going back to the cradle, but unconscious mistakes in reasoning made in the specific situations in which an inappropriate response is elicited. And in that way, help the patient restore themselves to emotional and mental well-being. Mental health is an accomplishment. It's an achievement. It's something that we all struggle with at some level. Okay, the third trend in the medical model, in the rise of the medical model in the 21st century, is the application of contemporary information technology in the study of human consciousness. And I must say that's how I got interested in the field and through the philosophy of mind. Now, the key idea here is the logic gate, defined formally by the mathematician Alan Turing way back in 1950, but brought into our lives by Steve Jobs and Mark Zuckerman, and scientists and artists and philosophers all over the world. We can now see on a daily basis how a physical thing, a silicon chip, can generate logic, language, art, music, a host of meaningful connections. And we all have had the maddening experience of watching meaningful connections in our electronic devices break down. Now, when that happens, it could be a hardware problem. I spilt my Coke on the laptop computer and it doesn't work anymore. Or it could be a software problem. A virtual virus inserted itself into the operating system of my computer and it doesn't work anymore. Or it's possible, it's not likely, but it's possible that the computer doesn't work because the software is corrupted and because it's a defective machine. And in that case, you might want to call an integrated computer care hotline. Synapses are logic gates. They either fire or they don't. But unlike computers, every synapse stimulates neuron growth and makes other synapses more or less likely. This is the cardinal principle of neuropsychology. It's called Hebb's rule. Neurons that fire together wire together. Neurons that don't fire don't wire. When a computer crashes, the device can be reinitialized because the logic gates can just be all zeroed out and then put in the proper sequence, and it should work fine. But when a mind breaks down, the breach in meaning is encoded in the growth patterns of the brain itself. To change your mind is to change your brain. Now, of course, people do sometimes just see the error of their ways, and start acting in ways that are reasonable and consciously decide to do something else. But the more deeply ingrained a thought pattern comes, the harder it is to change the neural network in which it's expressed. That's why habits are so hard to break. And that's why direct intervention on a synaptic level may be helpful, even necessary, for those who struggle with mental illness. So this is the cornerstone of the modern medical model. Psychopharmaceuticals modulate the biochemistry of synaptic gates in ways that enable the rational mind to reassert conscious control. Okay, quick example. This is maybe easiest to see in the case of anxiety disorders. And that's in part because the neuropsychology there is fairly well understood, unlike the neuropsychology of schizophrenia, which is deeply mysterious. What we've discovered by looking at the brain and studying it in a systematic way with those fMRIs and so forth is that consciousness itself takes time, at least a second, for something to bubble up to consciousness. And that's too long if it's an immediate threat. If the tiger's after you, you don't have a second to make up your mind. So people have a quick and dirty reaction system called the low road, and that keeps us out of trouble. When the crisis is over, we can sit back and think about it rationally, called the high road by neuropsychologists. And neuropsychologists have described the brain regions and the neurochemistry of the low road and the high road in some detail. We can talk about that if you'd like. Anxiety disorders themselves seem to arise when the low road reactions, a startle reaction, override or bias in a systematic way the high road appraisals of what a reasonable response is and what the threat actually might be. And the result is inappropriate response. So if the medical model is correct in this case, and in some ways this is a best case, then integrated care programs would seem ideally equipped to provide effective treatment. With informed consent of patients, behavioral screening for anxiety disorders could be conducted in the offices of primary care providers. In some cases, identifying the problem and advising the patient may be sufficient. In more serious cases, anti-anxiety medications may provide immediate relief. And cognitive behavioral therapy or other psychotherapy techniques can help the patient understand their condition, help them cope more effectively with intrusive thoughts and feelings. And long-term remission of anxiety disorders, including post-traumatic stress disorder, is associated. There is evidence that indicates that combined medical and psychotherapeutic interventions are most effective. So that would seem to confirm integrated care approaches. Okay, I need to make one last point. Philosophers are gadflies. Philosophers are people who sit back and ask questions about what is received wisdom. We have received wisdom right now in large measure that with regard to the medical model of mental illness. But a growing chorus of skeptics, you may have read about this, you may have heard about it, have begun to challenge the 21st century model of mental illness. The search for genetic biomarkers or genetic mechanisms for mental illness came up empty We haven't really identified the precise genetic mechanisms. We know there's an association, we don't know what it is. And nor has neuroimaging been as useful as you might hope. It can't be used for diagnosis, it can't be used for prognosis, it can't be used for individualized care. And again, this shouldn't be surprising from a conceptual point of view. An fMRI can indicate that someone is thinking, but that picture doesn't tell you what they're thinking about or whether it makes any sense. The meanings of thoughts connect us to the world, the inner world of our own minds and bodies and the wider social and physical world. Similarly with genetics, genetic traits are set before birth or epigenetically in aftermath. They cannot possibly determine meaning in this sense. And brain scans only tell us what's going on, what's going on inside of our head, not what's going on outside. And finally, most troubling of all, second-generation psychopharmaceuticals, they may be less therapeutic and benign than initially thought. In many cases, evidence suggests that antidepressants that regulate the neurotransmitter serotonin do not appear to be more effective than placebo, particularly if the placebo mimics expected side effects. Now, this is a mind-brain, mind-body connection. It's not saying that it's not effective. It's saying that it may not be effective in the way that we thought. Studies of long-term effects of these antipsychotic medications that I mentioned before, they suggest that they may have some of the same side effects as Thorazine. May also, long-term use of those may hold their own dangers. We don't know. They've only been used for a relatively short period of time. But there are some disturbing signs on the horizon. It's even possible that some of the epidemiological data is tracking the expanded use of the medications. It's possible that medical treatment intended to help people struggling with mental illness made them worse off. Wouldn't be the first time. I must also say, in conclusion, I must also say that biomedical research into the physiological basis of clinical depression and other disorders is a very active field. Promising results have been published just this year on the potential benefits of deep brain stimulation and chemically induced neuron growth in the hippocampus and other regions which are associated with mental illness. It's exciting. The secrets of the mind are being unlocked. Something that should stir the hearts of the philosopher and us all. And for those of us who work in healthcare and for anyone who's been affected by mental illness in some way, there is reason for optimism. Certainly with respect to integrated healthcare. Recall that the lower life expectancy of the mentally ill is due in large measure to ineffective treatment of cardiovascular disease, cardiopulmonary disease, and diabetes. Coordinated and comprehensive treatments of chronic mental and physical illness are low-hanging fruit for public health policy. Okay, my remarks are over. I'd like to say something about our distinguished guest.